So good morning, friends from all over the East. Actually, we are also part of the East, and uh, you all know each other. And so I'm from India, and I'm also heading the Dr. Center for Ophthalmic Sciences, which is the apex ophthalmic center for the government of India for the National Program for Control of Blindness. We also happen to be the collaborating center for prevention of blindness for Southeast Asia, and we have a number of countries from Southeast Asia who are with us, and so we also get to meet them at WHO. And the All India Institute of Medical Sciences, where we house, is a premier ophthalmic institution. We offer research, for residency training, as also for good clinical work, and it's renowned all over the world for this. This place is renowned all over the world. So I've been here for the last since I joined as a MD student, and I've devoted my life for this cause of uh, treating as well as controlling as well as preventing retinal blindness in my part of the country and in India. And so I'd like to just share of this talk which I have from my institution, and these are some of my thoughts which I'd like to share. It first time I think I get this opportunity, which I'd like to thank the AIOS and Professor Namta Sharma, Professor Mahipal Sachdev, for having given me this opportunity, rare opportunity, to get to speak to you all about what I think. Uh, so Pachychoroid disease is a enigma, I feel, because it's a group of macular diseases which manifest similar choroidal findings. So we've got diseases affect the choroid, like the Vogt-Koyanagi-Harada syndrome, but those are different. Those are inflammatory diseases. So this is something unique, that it has four entities with it, and often we see this pachychoroid pigment epitheliopathy, which is a form fruste of central serous chororetinopathy, which we all know, which is very common in India and my part of the country. And I get to central serous choroidopathy. And then we have pachychoroid neovasculopathy, which is only pure neovascularization, but you may be having pachychoroid with it. And I'll tell you what is pachychoroid. And of course, the most commonest entity which we'll be talking about today, and the most dreaded of all, is the pachychoroid choroidal vasculopathy. So these are the four entities which encompass this clinical spectrum. And this is it's called pachychoroid disease. So when we call it pachychoroid disease, and very interestingly, unlike AMD, it may not be a factor. You don't have it in the old age. It's depending on what age we get. And in my practice at the AIMS, or the RP Center of Ophthalmic Sciences, which is part of AIMS. So in short, I'll say the All India Institute of AIMS. We have these patients who have typically a hyper anxiety, stressful personalities. They suffer from emotional stress. They suffer from lack of sleep. The kind of people we see with pachychoroid disease, and often you have tobacco use or taking corticosteroids and to get together to understand these various diseases which are so common to all of us. It's there in Singapore, it's there in China, Japan, and so many other, Malaysia, are affected, and so are we. Disease, and it's over 50% of my patients OCTA, and more of resurgence of use of the ICG. I found we're picking up this disease more commonly. We're also looking at the choroid more keenly with the OCT angiography, and so we've been seeing these kind of patients, and we see them little less older patients. So a very important hypothesis which has been given is that by Bailey Fruin, who says that there's a multitude of pathogenesis. Actually, all we know is it basically causes pachy vessels which are dilated, engorged, packed with blood. Congested vessels, which are there, more of the outer blood vessels of the choroid, are congested. So it's not actually thickening of the vessel, but it's congestion of the vessel. So these congested, dilated vessels are called pachy vessels. There's also a heartability response on the ICG, and the vessels tend to leak, die. usually, and especially the inner choroidal vessels. There is also, as Bailey Fruin says, this venous collateral.
I think Dr. Atul is muted.
Yeah.
Dr.
You are
Atul,
muted, doctor. Yeah, you are muted.
Yes. Can you hear me?
Yeah. Good.
Yeah.
Yeah, it works now.
I can hear people.
Yeah, we can hear you in patches.
Yeah, now it's okay.
So it looks like we've lost Dr. Atul's screen now.
Atul sir's net is not working properly, sir.
So Harshit, what do you think is the issue? Yeah, I think we are.
Can you hear me?
Sir,
Yes,
it's
you
a net issue, sir, internet issue.
Yeah.
Connectivity.
Now it's okay.
So it's okay now?
Yes.
Yeah.
Clear. Please proceed. Yeah.
Yeah, okay. So
Yes.
you get increase in the thickness of the choroid, which is because of the congested vessels, and you get these strange drusen which are large in size, greater than 124 microns, and they're spread as cluster or scattered. So around the posterior pole, and they may be there all over around the posterior pole. They got pachydrusen, like pachyvessels, pachydrusen, increased choroidal congestion, and some congestion, ischemia because of the narrowing of the satellars and the choriocapillaries. So, as Bailey Fruin says in his recent article, that there's some choroidal venous insufficiency, he says, but this choroidal venous insufficiency is a thought which was proposed by Januzzi and then passed on, and so the choroidal venous insufficiency may lead to choroidal, venous collaterals, and venous collaterals sort of congestion in the veins. This congestion in the veins leads to thickened vessels, thickened choroid. So it can occur in any kind of Pachychoroid disease, can occur in any kind of choroid thickness. The multimodal imaging shows attenuated inner layers. So the inner layers are kind of mechanically compressed as well as ischemic. They're ischemic and compressed by the dilated Haller's layer, which are the Pachy vessels. And so one part of this entity of Pachychoroid disease is the most commonly seen, which is more causing blindness besides CSC, is Pachychoroid choroidal vasculopathy, and is characterized by type 1, that is between the RP and the Brooks membrane. You have the type 1 neovascularization, with aneurysms. Is terminology which I'm using. So the pachychoroid epitheliopathy is a form frustrated of settled serous choroidopathy where you have these pigmentary deposits, but no classic evidence of new vessels or just fluid or a pigment. There's a pigmentary abnormality in the AF on the color picture, and if you see the OCT, also there is a thickened or dilated vessels, but the retina seems to be normal. So then comes to the central serous choroidopathy, where you have these blister-like lesions at the posterior pole, often younger patients. As I said, they are hyper-stressed, anxiety, which is so prevalent in our country also, like many other countries probably, but I get to see a lot of these patients of CSC, and you always look at the choroid is showing thickened choroid, larger thickened vessels because of the congestion, and you can see some smokestack leak over there. So this is a patient who was unfortunately given intravenous methylprednisolone, thinking it was Vokoyanagi Harada, because, as I said, these inflammatory disorders like VKH or Vokoyanagi Harada may have a thickened choroid, and they may mimic. And so people may give an error, give steroids which are actually contraindicated for patients of central serous choroidopathy, and central serous choroidopathy is a part of the pachychoroid spectrum. So steroids are contraindicated. So this patient had huge leaks with fibrin deposit, and there was a pigment epithelial detachment, and a lot of serous fluid, which stopped and after discontinuing the steroid intravenous. Now, OCT, I give a lot of importance to it, and you can see the branching vascular network. I feel that the treatment of polypoidal choroidal vasculopathy is to a great extent dependent now, I feel, that it's dependent on the OCTA picture. Because I've seen patients of pachychoroid choroidal vasculopathy actually bleeding if on the base of OCT only if there's no fluid and there's no presence of active disease. But if the OCTA shows me a large vascular network, I would like to treat. This is a type 1, which is in the between the RP and the Brooks. So you can see the double layer sign, which is there, the type 1 neovascularization, and the large choroidal vessels which are abutting onto the degenerating RP. So polypoidal choroidal vasculopathy, which is the most important of all the 4 entities which are there under the pachychoroid disease spectrum, has a predilection for the Asian ancestry. What I like to tell my colleagues and my friends from the Far East, that we also happen to be in the same territory as you are, and I get to see a lot of these pachychoroid disease patients, maybe more than 50%, and we've published data in our Indian news journals, as well as we have some data abroad also. So we've seen it as a standalone clinical entity or as a variant of neovascular AMD in a younger age group. There's a variant probably having thick choroids, irregular PDs, and often we see patients of chronic CSC going into a stage of polypoidal choroidal vasculopathy. And so all patients of CSC have a OCTA definitely done, because I find the OCTA or the angio-OCT really helps me to see the new vessels very clearly, unlike the ICG. So I see this bunch of polyps or aneurysms, as they call it, along with the new vascular branching vascular network. And you can see these multiple sharp PDs, or they say bifid or notched PDs with the thumb-like PD or sharp PDs. These are very characteristic of a branching vascular network with large dilated vessels. Normally, the thickness is less than 300. If it's more than 300 microns, we take it as pachychoroid disease. So this is one of our articles which was published in 2019. And this is another patient. We do get to see a lot of bleeding in our patients in my center, and I like to then use which I'm going to hear right now at the end of this one of the talks. Look forward to it. I look forward to Jimmy Chewing's talk also on the non-ICG features. I look forward to Timothy Lai's talk. So I inject about 12.5 micrograms in 0.1 ml TPA. I give about less than 50 micrograms total. And I injected with Avastin along with the air, and I injected into the sub with a 41 gauge translocation needle. I put the cocktail inside, and talking about here. And as I told you again, that I have started giving a lot of importance in the last 1 year to OCT angiography or angio-OCT for the follow-up patients of PCV. And this patients tend to do better than neovascular AMD. They're at a younger age, definitely. they have a tendency to develop polyps. They have a thicker choroid than neovascular AMD, classically seen in Caucasians. They probably require a lesser number of injections, but they definitely do require photodynamic therapy if they're not responding. And visual acuity is probably doing better if they get injected as and when required. So for photodynamic therapy, unfortunately, it's not available a dye right now in India. I think Novartis has sold the rights to some other company, and we're still waiting for the dye. I'd like to know what's the situation in the Far East. So we see this polyp disappearing after treatment, and patients responding very well. So I use reduced fluence or half fluence PDT. This is just a video showing the patient who bled, how we treated it, and how do I treat it. So I just want to show this. Of course, you got to talk on this, but it's just to tell you this is a bleed which involved the fovea. So once it's involved, the fovea is going to destroy the photoreceptors and lead to irreversible visual loss. So I like to put a little triamcinolone and induce PVD because until you induce the PVD, we can't do the surgery. And then with IOST guided, I like to first identify the area which is not the subretinal space, which is benefit of any PD. And so I put the 41 gauge self-sealing retinotomy and inject this TPA Avastin air cocktail. And those patients do extremely well. And that's all I'd like to say. Thank you very much.
Thank you,